ClinHaem, Hematology, Demystified.
The diagnostic pathway in hemolysis, and the role of the direct antiglobulin test. Part 2 of 4, from ClinHaem's FRCPath Masterclass Series on autoimmune hemolysis.
Now, the slides from here on are about autoimmune hemolysis. So where does autoimmune hemolysis fit into the hemolysis world? So into the causes of hemolysis. So always good to divide causes into some sort of pattern. So I like this for most of the things. So hereditary causes or acquired causes. Now, red cells only have three things. They've got a membrane, they've got some enzymes in the cytoplasm, and some hemoglobin in there. Problem with any one of them can cause hemolysis. Acquired can be immune or it can be non-immune. Now, immune can be autoimmune, so your own body producing autoantibodies against your own cells, and that can be warm or cold, and we will discuss that in quite a bit of detail today. But of course, it can be alloimmune. So, for example, hemolytic transfusion reaction. So a donor blood cells going to a patient will make antibodies against the donor antigens if they are foreign to the patient, and that's an immune mechanism, but that's alloimmune. Drug induced, so some drugs can also initiate an immune response, which otherwise would not have been there, so against the cells. So what we will focus on is basically the autoimmune part here today. And the list of non-immune causes is very, it's quite a huge list, but most common, what we need to, or important ones that we know as hematologists, of course, are PNH, TMA, DIC, but there are others like oxygen substances, including dapsone or rasbudicase, etc. And infections, of course. Prosthetic heart valves and heart problems are quite important as well. And I do plan to make a separate video of an interesting case that I will share afterwards of hemolysis related to something to do with the heart. Okay, so that's the list of causes, and of course, I'm pretty sure you know most of them anyway. But this is quite an easy exam question, differential diagnosis of causes, and quite some easy marks there. Okay, so now going on to the difficult bit, or not the difficult bit, but the complicated bit. So if you're asleep till now, maybe want to pay some attention here. Unless, of course, you know everything already, so that's fine. You can still stay asleep. So, number one, is there hemolytic anemia? And we have discussed the way to do that is answer that is low hemoglobin plus concordant hemolysis markers, or even normal hemoglobin compensated hemolysis can be there as well. But anyhow, but if you're saying hemolytic anemia, of course, hemoglobin needs to be low. First step, is there hemolytic anemia? Next step, is the hemolysis immune? So the test that we do is DAT, which is direct antiglobulin test, also called direct Coombs test. But what is that? DAT is a very important test in hematology, and I will try to explain that here. So what we do is we take the patient's red cells. These are patient's red cells. In this instance, they are covered by some autoantibodies in blue, and we will expose them to direct Coombs, to the Coombs reagent, which is basically shown in green here. So basically, direct Coombs reagent is just antibody against human antibodies or complement. So Coombs reagent is just a mixture of antibodies against human immunoglobulin and complement. So this is just Coombs reagent. So if you add that here, especially in this patient, what you would see is this anti-human immunoglobulin in the Coombs reagent will bridge the autoantibodies, bring the red cells together, and cause agglutination, which is seen here. This is one of the methods to do that. So this is a positive reaction for agglutination, and we will say that the DAT is positive. So patient cell plus Coombs reagent, if there is agglutination, that's DAT positivity. Now, why is this positive? Simply because the patient cells were already coated with an antibody, autoantibody here, and this reagent was able to bring them together, cause a cell agglutination, and this is a positive DAT. So you would have been happy days here, and you do one test and say, okay, autoimmune hemolysis is diagnosed and sorted. Let's go home. But The problem is that will not differentiate if the same antibody that's coating the patient's cell is something else, like some so IVIG. So as you know, we do give IVIG, which is a treatment, which is basically a treatment containing just immunoglobulins, human immunoglobulins. So if you give that to a patient, those immunoglobulins will coat the red cells. And now if you do a DAT on them, that would still be positive. So that doesn't mean that they've got autoimmune hemolysis now. It just means you gave them IVIG. Those immunoglobulins in the IVIG have coated the cells. You provided that Coombs reagent, and that reaction is positive. So that positivity just means the red cells are coated with immunoglobulin or complement, because the Coombs reagent has antibodies against the human complement as well. So that's what that means. It would just that will just tell you, direct Coombs test or direct antiglobulin test will just tell you that this particular patient's blood cells are coated with antibodies. That's all. It can't tell you if they're auto or allo or it's just IVIGs or whatever. So that means, so a bit more about that because this is again very important. As I've said, that reagent is just a mixture of anti-human globulin, and that has got specificity against both human IgG and other complement. Sorry, they've got, since they basically got that reagent is just anti-human globulin with which has got activity against human immunoglobulins or complement. Now, what most labs do, they use what is called a polyspecific DAT reagent. So as a screen, so in their DAT reagent, they would have polyspecific anti-human globulin, which has got reactivity against just the IgG and anti-CD3, but in one. So their DAT reagent will be able to pick up any IgG coating the cells or any C3d, which is a complement breakdown protein coating the cells. So what that would answer is, do red blood cells have IgG or complement coating the cells? That's all what the DAT screen would answer. But that is not perfect, as I've said, because there is autoimmune hemolysis, first of all, which is DAT negative, and that can be in up to 10% of the autoimmune hemolysis patients. They have DAT negative AIHA. And especially if say you do the polyspecific DAT screen as above, and the patient has got autoantibodies which are say IgA type, which is rare but there. So the patient's autoantibodies are IgA type. The DAT screen using this specific reagent won't pick it up. So what the trick is, you always send monospecific DATs. Monospecific DAT means in this time the reagent will have antibody against a specific immunoglobulin subtype or a complement subtype. So that would be like 5 different reagents. The first reagent has got antibodies only against IgG. Second has got only against human IgA. Third has got only against human IgM, and so on. But also, if that's got it's not, if the red cell is coated by only a few antibodies, say less than 100 per red cell, then most DATs won't be sensitive enough to pick it up. But these antibodies can still be, even though say there are only 50 antibodies coating per red cell in a patient, but those antibodies can cause significant hemolysis. So they're not benign antibodies, they can cause hemolysis. But our DAT screen would be negative. So there it goes. That's the problem here. So it can be less sensitive. Now, it can be false positive, quote unquote, as I've said. First of all, say you've given somebody, passive deposition of immunoglobulins, for example, from IVIG, as I mentioned, or even things like autoimmune disease like SLE. Patient is going to produce lots of autoantibodies. It's just going to coat the red cells, but not cause hemolysis. Your DAT would be positive, but there is no hemolysis. Similarly, infections can cause autoantibodies and other conditions. But there are other reasons for a positive DAT pathologically. So, for example, a blood transfusion with a hemolytic transfusion reaction, for example, a delayed transfusion reaction. The patient has had blood transfused from a donor, and some of the antigens would be foreign to the donor, so foreign to the recipient, and the recipient, which is the patient, will make antibodies against the donated cells, and they will coat them. Now, when you take a patient's sample, it will have those donated cells coating the patient's antibody, and it will be picked up by the DAT screen or DAT test, and it will show a positive DAT, but that doesn't mean this patient goes autoimmune hemolysis now. It just means, again, as I've said, patient's cells or the cells that you've taken from the patient, they're just coated with some immunoglobulin. And lastly, one of the biggest problems is that is actually very common. So if you were to randomly screen donors, which are healthy donors, of course, not having hemolysis, you will see a positive DAT in quite a bit of them. So you cannot just rely on a positive DAT to say they have definitely got autoimmune hemolysis. You have to have the right clinical setting as well, and you have to exclude all of the other causes for a positive DAT. So going back to the diagnostic process for AIHA, number one, is there hemolytic anemia? We've seen, okay, the hemoglobin is low and these hemolysis markers are in the right direction for it. You would check, is the hemolysis immune? That is positive. Okay, suggests there are antibodies coating the cells. Maybe the hemolysis is immune and maybe those are autoantibodies, but you have to exclude all the other causes for positive that I've mentioned before saying, okay, this is AIHA. And once you have done that, then okay, all the causes you have excluded that you can, and they're clinically relevant, okay, you will say now the patient looks like he has got autoimmune hemolysis. And this is where it gets slightly more tricky, but after that, this is all nice and easy and happy days because it's quite straightforward. And this is what causes quite a bit of headache to people preparing the exam, but this is very important for real life as it is for the exam setting. Once you've diagnosed that this is AIHA till point number 3, you want to do a few more steps to check for the subtype of AIHA, which is the tricky bit. And also for any underlying causes, which is relatively the easy bit, because if this is secondary to say a viral infection, you do virology. If you're suspecting a malignancy, that's triggered, you do imaging, etc. So first, I will just briefly mention the classification and types of AIHA. But actually, has anybody got any questions till here, especially the DAT thing?
Coming up next in the series on autoimmune hemolysis.
Thank you for watching. Stay tuned for more.